Chapter 11. Heroin. A few key facts. Heroin is a semi-synthetic substance derived from opium extracted from poppies. It's an opioid depressant. It's not one of the most popular psychoactive substances, but with a disproportionate number of deaths from using as the risk of overdose is high and can be fatal. It's usually smoked or injected. Some effects include a rush of euphoria, pain relief, relaxation, nausea, slow and shallower breathing, and a weakened pulse. When I was growing up, in the 1980s and 1990s, heroin was portrayed in the media as the demon drug. A drug that was linked to the most terrifying illness of the time, AIDS. A drug that seemed to lead to addiction in almost everyone who used it. Trainspotting was the first film I ever watched in surround sound, an odd choice, I know. It didn't shy away from portraying the risks of injecting, or the lifestyle and environmental factors that might lead someone towards starting to use heroin and developing a problem with it. But how realistic was its and my perception of the drug? Is one use really all it takes to develop a habit? What is it? To start with the basics, heroin is the street name for the compound diamorphine. It's semi-synthetic. Opium from poppies is chemically processed to make it stronger. Stronger meaning a lower dose is needed to get the same effect, not that the intoxication effect itself is stronger, an important distinction. Heroin produced in different regions of the world can have different appearances. Sometimes it can be found as a white or brown powder, while it can also be encountered as a thick solid known as black tar heroin. Heroin is an opioid, the name used to refer to substances derived from opium poppies. Technically, opioids are substances where some chemical alteration has been made to opium, so synthetic or semi-synthetic substances, whereas substances like morphine and codeine that can be extracted directly from opium are known as opiates. Having said this, these terms are now often used interchangeably. Interestingly, humans also have a number of endogenous opioids, that is, compounds similar to opium from poppies are made by our bodies. There are a few of these. One is endorphin, the chemical our brain releases to inhibit pain and induce euphoria. We have opioid receptors in our brain and nervous system because of these endogenous opioids, and it's at these sites that external opioids and opiates have their effect. Heroin can be consumed in a number of ways. The powder can be smoked. I use inverted commas because smoking suggests burning, but really the powder is heated and the vapour inhaled. It's more like vaping than smoking. If you've heard someone talk about chasing the dragon, this is what they're referring to. Heroin powder is placed usually in foil and heated from below, and a tube can be used to inhale the vapour. Heroin can also be injected. In this instance, the powder needs to be combined with an acid of some kind to create diamorphine hydrochloride. This can then be injected into the bloodstream either directly into a vein or under the skin or into a muscle. It's also possible to snort heroin, although this method of consumption is less common. Heroin can also be plugged rectally. This is where it's put in a syringe without a needle on the end and pushed into the anus. Women can also consume it vaginally. As with other substances, the method by which you consume it impacts on the intoxication effects. Injecting into the bloodstream is the most efficient way of consuming a drug, if by efficient you mean faster acting. Injected heroin can cross the blood-brain barrier within seconds. Inhaling the vapour is a little slower, but still a pretty quick route to intoxication. What are the short-term effects? The initial intoxication experience is often described as a rush of euphoria. How intense this rush is will depend on a number of things, including the method of administration. If heroin is injected into a vein, this will be intense and almost immediate. The effect will be diminished if injected into a muscle or under the skin, subcutaneously. If consumed via snorting, it'll be still less immediate and intense. Heroin is a sedative, so it will make a person feel peaceful and relaxed. However, it can also induce nausea and vomiting, particularly in those who are not experienced users. This is similar to morphine. Some people given morphine in a medical setting will find it makes them feel really sick. The combination of sedative effect and risk of vomiting can be dangerous too, increasing the risk of choking on vomit while passed out. Heroin can also cause constipation. Take too much heroin and overdose risks are extremely dangerous. Heroin will suppress breathing, sometimes called respiratory depression, which can become shallow or even stop. Your pupils will shrink, your extremities and lips can go blue. You might have seizures or start shaking, your pulse will weaken. An overdose can be fatal. Although, if countered quickly, it can be reversible. If a substance called naloxone could be administered to a person who has overdosed, this compound will bind to the sites in the brain where heroin binds and prevent heroin from doing so. It will bring the person out of overdose and straight into withdrawal, but it could save their life. The UK is currently introducing the provision of naloxone to police forces and the peers or family of people who use heroin, in a similar way to EpiPens for people with severe allergies, insulin for those with diabetes, or drugs such as midazolam, a benzo, for people with untreatable epilepsy. There are also risks from using heroin because of its illegality. There are great risks from consuming an illicit drug via injection. Firstly, where do you get your needles? Often this might mean reusing needles, potentially even sharing them. This is a huge risk for the transmission of blood-borne diseases. The most well-known in relation to heroin use is probably HIV, that causes AIDS, but hepatitis B and C are possibly even greater threats, particularly as treatment and prevention of AIDS improves. Frequent injections can cause collapsed veins, bacterial infections of the skin and soft tissue, and the risk of abscesses and gangrene. In severe cases, this can lead to amputations of limbs, or death from septicemia or bacterial endocarditis. On top of this, as I mentioned earlier, when you inject heroin, it needs to be mixed with an acid in order to allow this. If you don't have access to medical-grade acids for this, you might think that using something like lemon juice would be okay. But using lemon juice in this way has been known to cause fungal infections, including inside the eyeball. Yikes. So given this risk, why do people take heroin? What's the appeal? The euphoric rush described earlier, for one. The cliché from Trainspotting is that it's better than sex, and this analogy might not be too far off. Endorphins, our endogenous opioids, are released during sex. And what leads people to continue using? If you become dependent on heroin, then a strong driver for continued use becomes bringing yourself out of heroin withdrawal. More on this later. What are the longer-term effects? If you use heroin regularly, there are longer-term risks. If you take heroin daily or near daily, you'll build up a tolerance. You'll no longer get the same rush from the same dose, and you'll need to keep increasing it to get an equivalent high. And the feeling of the rush decreases over time too. This can mean that soon you'll feel you need heroin to make you feel normal, and if you develop dependence, it may feel like you need heroin to bring you out of withdrawal, which can be extremely unpleasant. So what is withdrawal? It's not nice. It can feel like heavy flu, and I don't mean like a bad cold, where it's a struggle to function or do your daily chores. I mean full-on unable to leave your bed flu. You can experience heartburn, sleeplessness, depression, anxiety, paranoia, cramps and vomiting. As with lots of other drugs, withdrawal symptoms are the opposite of intoxication effects. Using heroin induces constipation, so as you might then expect, withdrawal can cause diarrhea. The physical symptoms of withdrawal will pass after around 4 days, but it'll be a while before you start to feel better. The parallels to flu are many. Breaking the psychological dependence can be even harder. A further risk from heavy regular heroin use can be that due to the numbing and sedative effect of the drug, it can be easy to neglect taking care of yourself. This may be why some people who are dependent on heroin can have poor skin or lose teeth and are often underweight. It's not a direct biological effect of the drug necessarily, but related to the effect the drug might have on motivation, and indeed related to who might find themselves dependent on heroin. It's safe to say that heroin dependence can hugely impact on a person's life. But some of the things I heard about heroin when I was a teenager in the 1990s simply aren't backed up by evidence. Myths and misconceptions. 1 dose and you'll be hooked. It is impossible to get addicted to a substance, any substance, after one use. It's possible to enjoy it after one try, to be really keen to take it again because the experience was so pleasurable, whether in a hedonistic way or in a way of making your circumstances or situation more bearable for a few hours. But you cannot become dependent on a substance from using it once. And fewer people than you might think actually develop dependence on heroin. According to the American Society of Addiction Medicine, the ASAM, around 23% of those who try heroin will develop opioid dependence, suggesting that 77% of those who try it won't. Other experts have questioned these figures, believing they might underestimate the number of dependent heroin users because of how they are conducted. General population surveys or household surveys, for example, may underestimate the number of dependent users, as these individuals are at a higher risk of being in prison or without a fixed address due to their heroin dependence. If these people are systematically underrepresented in these surveys, it would lead to a bias that would suggest heroin was less dependence-forming than it truly is. So what is the real figure? It's hard to say. A small study attempted to account for this bias and found some evidence that the figure might be closer to 50-50, or even around 60% of those who try heroin will develop dependence, although their estimate is very uncertain due to assumptions they had to make and the small sample size. Animal studies also suggest the risk of dependence is higher than the ASAM's estimate. But humans are not rats, so again, it's hard to conclude anything definitive. But whatever way you slice it, there's absolutely no truth in the idea that you only need to try heroin once to become addicted to it. It's a myth. All heroin users are addicted. As we've seen in the previous myth, many people who try heroin will not develop dependence on it. As for people who start using regularly, well, does regular use mean addiction? This really depends on what you mean by addiction. Regular users of heroin will develop tolerance to the drug. They will experience withdrawal if they stop taking it, and so they are likely to be considered dependent. Addiction is often defined as the continuation of a behaviour, even when there are real or potential harms from doing so. It is likely that regular use of heroin will lead to harms, particularly if the substance is consumed illicitly, as it's likely to be, and is injected. This would in all likelihood impact on an individual's lifestyle and quality of life in a negative way, making it harder to hold down work or personal relationships. But long-term addiction isn't as inevitable as it's often perceived, so this is a myth. The drug perpetuates the addiction and circumstance has no effect. It's a theme throughout this book that a huge factor in your experience of taking a drug will be the two S's, set and setting, and so it is with heroin. Researchers have interviewed people who use heroin and found that they experience overdoses more often when consuming the drug in locations where they've not previously been before, or when circumstances are different. So the setting is clearly very important here. It seems that the body somehow prepares for or expects heroin when cues that are associated with using heroin are present in the environment, although how it does this is currently not known. This idea of the importance of setting or circumstance is also vividly shown in research conducted in the USA during and after the Vietnam War, where many soldiers who had become dependent on heroin or opium while serving in Vietnam did not continue to use the drug once they left the war zone and returned to their homes in the USA. There's more detail and discussion about this study in the addiction chapter, should you be interested. So this is a myth. Abstinence is the only cure for heroin addiction. While the only way to ensure that you will not experience any harm from a substance is not to take it, if you want to reduce your risk of harm from heroin without stopping taking it, this is possible. Taking it less regularly, leaving at least a few days between uses or ideally even longer, will reduce the physical dependence on heroin. If you're consuming heroin via injection, then changing to a less immediate method of consumption, such as snorting or inhaling, will reduce harm and could help reduce dependence. Similarly, if you do continue injecting, then finding a source of sterilised needles and acid can reduce your risk of harm. In the UK, there are needle and syringe programmes, and there's discussion in Scotland at present to introduce injection rooms where people can consume the drug as well, rather than having to take sterilised equipment out into non-sterile environments to use it. Injection rooms have been implemented successfully in many other countries around Europe, including Switzerland, Germany, Spain, Norway, and France. Many are opening in Canada in response to the opioid emergency occurring in North America. If you want to stop taking heroin, then you can get medical help. In the UK, doctors can prescribe heroin substitutes, commonly methadone or buprenorphine, also known as Subutex. Methadone is a synthetic opioid similar to heroin. It's usually administered at selected GP surgeries as a green liquid. Doses are given one at a time to consume on the premises. As it's similar to heroin, if you continue to use heroin while taking methadone, it's easier to overdose. Buprenorphine is a little different. If you've taken buprenorphine, then this will block the effect of heroin if you take that as well, making it harder, although still possible, to overdose, but also meaning that taking heroin will not be as pleasurable anymore. For this reason, people who are prescribed buprenorphine will sometimes stop taking it so that they can resume use of heroin once it has left their system. It's believed that withdrawal from methadone is less severe than withdrawal from heroin, although the evidence to support this isn't completely conclusive. There is a debate among public health and medical researchers about whether people who have successfully moved from using heroin to using methadone should be maintained on methadone long term, or whether the goal should be complete withdrawal from everything eventually. So this is a myth. Why is it so hard to stop using heroin? As we've already mentioned, heroin is dependence-forming if used regularly, and withdrawal symptoms are really unpleasant. But often it's hard for some people to stop using heroin for environmental or external reasons, rather than or as well as the physical dependence. If, after detoxing from heroin, you return to the environment where you've always taken it, the cues that you associate with the drug might make it seem very tempting again. If your group of friends are using it and it's easily available, the temptation to use it again will be higher. Heroin is a drug that's often used by people who have very difficult lives, so unless a person's circumstances change, the urge to use heroin may well remain. All of these factors can play a role in why it's hard to stop using heroin, and why people relapse even after they are no longer physically dependent on it. Why do people overdose on heroin? It's really dangerous to take too much heroin, in severe cases fatal. And for a number of reasons it's quite easy to do this. Firstly, if you're injecting a drug, there's nothing you can do about altering the level of the dose once you've consumed it. Once you've injected it, it's in you. With something like alcohol, if you drink too much, one of the first things that your body does is try to expel this by vomiting. This won't work with heroin because it's not in the stomach waiting to be absorbed, it's already in the bloodstream. Because of heroin's legal status around the world, it can be even harder to ascertain correctly the dose required because there's no way of knowing the purity of it or what it's been mixed with. Samples of street heroin seized in the UK have been found to be mixed with paracetamol, sugar, and sometimes other sedatives. This can make it extremely unpredictable, as some of the substances might interact with it and exacerbate the effects of heroin, increasing the risk of overdose or side effects. In recent years, heroin laced with fentanyl, a more potent opioid, has been found in circulation. This can greatly increase the risk of overdose. Also, as we've already discussed, the setting in which you consume heroin can impact on the likelihood of overdose, with this being more common in novel settings. Tolerance to heroin can fall quite quickly if you don't take it for even as short a time as a couple of days. This means if your supply runs out and you can't replenish it straight away, or if for any reason you stop using for a few days, the next time you use it, you'll need to take a smaller dose. Does heroin have any medical uses? While there is an argument to be made that some people use heroin as a means of escape from their circumstances for a few hours, which could be seen as self-medicating, using heroin in this way will be a short-term solution to a long-term problem, and will certainly do an individual more harm than good. While intoxicated on heroin, people may be even less likely to seek help for the problems that led to heroin use in the first place. However, morphine, a compound very similar to heroin, is extremely useful as pain medication across the world. It's prescribed for acute pain, from heart attacks to cancer, and is likely to be the first choice for prescription unless a person has allergies to it or has previously suffered serious side effects from it. Is it right to prescribe morphine or other opioids for non-cancer chronic pain? Some believe overprescription is in part responsible for the opioid crisis that countries like the USA and Canada are experiencing. This is covered in more detail in the prescription opioids chapter. Focus on drugs and mental health. There's a strong link between drug use and mental health problems. This is true of a lot of substances, including alcohol, cigarettes, and cannabis. And it's true of a number of different mental health problems, including depression, anxiety, and even more serious conditions such as psychosis or schizophrenia. We know this because we see substance use at higher levels in people with poor mental health. We also see rates of poor mental health at higher levels among people who use substances, and people who are heavier users of substances than people who don't use them. The difficult thing is untangling what this association means. It could be one of a few different things, or potentially some combination of all of them. Drug use causes poor mental health? The first interpretation is that taking a substance causes an increase in risk for poor mental health. There's some evidence that points in this direction. We know that psychoactive substances impact on some of the brain pathways and neurotransmitters that we think are also implicated in poor mental health, which could be an explanation. Also, substance use has often started before poor mental health symptoms are reported, which could suggest causality is going in that direction. People with poor mental health seek out drugs. Another explanation for an association between drugs and mental health could be that people with poor mental health are more likely to use drugs because of their poor mental health. This explanation also makes a lot of sense. When people are asked about their motivation to use substances, a lot report doing so to cope. We see this with alcohol, opioids, and other substances too. If a drug can numb painful feelings, help a person to get to sleep, or even just provide a break from unpleasant thoughts, it's easy to see why people might turn to it. Particularly in a society where we don't have perfect treatments or support for people experiencing difficulties with their mental health, and where many people go untreated. Earlier life factors influence both, and the association is just coincidence. There's a third possibility as to why we see a link between drugs and mental health. It could be that factors, be they genetic or environmental, might influence both things, and the link we see between the two is simply an artifact of something else going on. There's also some evidence to back this idea up. Early life or childhood trauma is a strong predictor of both a likelihood to use psychoactive substances and a likelihood to experience poor mental health. And there might be loads of other factors that could influence this too. Untangling it all. Working out which of these is the true reason for the association between drugs and mental health is really hard. And I speak from personal experience here. My research is specifically trying to unpick this question, and I've been doing it for over a decade now, and I don't have any definitive answers yet. My hunch, though, which is evidence-based as much as it can be, is that in all likelihood it's a combination of all these possible explanations. People who are predisposed biologically or environmentally to use a substance are also those who are at higher risk of poor mental health. They might start using a substance initially to deal with difficult symptoms, but unfortunately the substance might be effective in the short term but make matters worse in the long term. What's also important to note is that these associations get stronger when we focus particularly on the people who are dependent on a substance or have problematic patterns of use. This would also fit with this working hypothesis. We know that when a person starts to rely on a substance, this can be an indicator of increasing risk of harm in terms of dependence or addiction, but also in terms of other difficult factors in their life that maybe are not being addressed.